So I was invited here today to give a quick presentation about dosing software and how it can be used in conjunction with therapeutic drug monitoring to increase the proportion of our patients that actually achieve therapeutic targets. So I've got no conflicts of interest to disclose. This is just a quick outline of the different topics that I'll be talking about today. So we'll briefly cover some of the challenges that are associated with therapeutic drug monitoring and potentially how dosing software can help target those challenges. Broadly speaking, there are about 3 to 4 different types of dosing software, and the differences between them is essentially the model that underpins them. So you've got linear regression programs, you've got pharmacokinetic model programs, or you also have dosing programs that use Bayesian forecasting. And artificial intelligence is a new and interesting one, which we'll talk about a bit later as well. And we'll try to briefly cover the evidence for each of the different models that are out there. So we've had a lot of talks today about therapeutic drug monitoring today, talking about how we need to achieve fixed concentrations or target concentrations to ensure that our patients have optimal outcomes. Now, it's not as simple as just collecting a single sample and that gives you an answer, because as we've heard today, some medications such as aminoglycosides or vancomycin, the efficacy of those agents are best described by something called the area under the curve. Now, to actually calculate the area under the curve, it often requires complex calculations that most clinicians probably aren't familiar with unless you've actually had pharmacokinetic training in the past. And even if you did have that, you often need multiple samples, usually about 2, to be able to calculate or quantify an AUC. We've heard Susie talk about some of the challenges associated with collecting more than 1 sample, and pediatrics is certainly another cohort where you might have difficulties with this. The other thing with therapeutic drug monitoring as well is we often need to wait for steady state to be achieved before we're able to actually do the sampling. And that's predominantly because if you collect a sample a little bit too early on in the treatment course, you might over or underestimate the dose changes that you will need to achieve to get your therapeutic target when it actually gets to steady state. So that potentially opens your patients up to about 24 to 48 hours of potentially inappropriate dosing before you're able to actually get a TDM result. It obviously requires appropriate timing as well. I'm sure most of you who are familiar with vancomycin trough sampling will be aware of this. You know, the sample gets taken too early, you'll end up having to repeat it because you're not sure if it was taken at the right time, whether the concentration would have been therapeutic. Changes in patient parameters is another big issue. Say, for example, your patient has been stabilized on a particular dose of vancomycin or aminoglycoside, and then they suddenly have a change in their renal function. Now, we know renal function impacts on the clearance of these agents, but we're not really quite sure how much to change the dose of the antibiotic by without performing another subsequent TDM response or TDM sample, sorry. So again, that opens up the patient to another 24 to 48 hours of potentially inappropriate dosing. And I think the biggest challenge for most clinicians is even if all of your ducks are lined up in a perfect row and you get your target concentration or your target exposure, how much do I actually need to change my dose by to actually achieve a target? And this is where dosing software can potentially come in. This is just a quick recap of the different parameters that best describe exposure of antibiotics. So Cmax and time of MIC are probably fairly easy to quantify. It's either just a trough sampling or a peak sampling just after the dose is given. And it's the AUC that's often the trickiest one to calculate. So the first and probably the simplest of all of the available dosing programs out there is something that utilizes linear regression statistics, I suppose. Essentially, these dosing programs require clinicians to obtain 2 different concentrations at 2 different time points. And you can see this on this graph here. All of this work is done by the dosing software. You start your patient on a particular dose of an antibiotic. We'll pretend it's an aminoglycoside. After giving the dose, you collect a sample at this first time point here, and then several hours later, you collect a second time point here. What the dosing software will then do is make a prediction in terms of what is the likely overall concentration that the patient is likely to achieve. And it essentially extrapolates this entire line here. And the nice thing about these programs is it automatically calculates an area under the curve based on these 2 time points here. Now, if you actually included additional patient parameters such as renal function, weight, height, and age, you can actually calculate an actual other pharmacokinetic parameters as well. So things like clearance or volume of distribution, if that's something that you're interested in. Probably the two most famous or commonly used programs are either antibiotic kinetics or Aladdin, so aminoglycoside levels and daily dose indicator. So these are predominantly used for aminoglycoside dosing. So the handy thing about these programs is they automatically calculate the AUC as discussed in the previous slide. And if your AUC is subtherapeutic or toxic, it'll automatically generate a dosing recommendation that is likely to help you achieve your target AUC. Now, it actually does generate a report that you can include in your medical records as well. So it makes it really easy for clinicians to be able to quickly justify to their other colleagues in terms of the reasonings behind the dose changes. Problems with this particular form of dosing software is that there's actually very limited prospective data covering these programs. What I mean by that is, say, for example, you have a patient who's being commenced on a particular dose of the antibiotic. We know that the concentration is subtherapeutic, and you've popped that into your dosing software. The dosing software spits out a dose that it thinks that your patient needs to receive before it'll achieve the actual therapeutic target. Anecdotally, from clinician experience, we think that it's a pretty accurate way of doing it, but there's not actually a lot of data out there that has prospectively investigated the accuracy of that particular approach. Now, a study that was done in the late 90s by the Patterson group actually compared the use of Aladdin to dose aminoglycosides compared to clinicians who dosed aminoglycosides using a dosing nomogram. And what they found is patients who received their dosing using Aladdin actually had lower incidence of nephrotoxicity. So they had an incidence of about 13% compared to the clinicians who used a nomogram, and they were about 19 to 20%. Now, unfortunately, they didn't have any clinical outcomes in this particular study, but there was a comment that in the patients who received Aladdin-dosed aminoglycosides, there was an 85% clinical cure rate in that particular group. But we don't really know how the clinical cure rate compares between the two groups. Now, just to be aware that Aladdin is actually no longer supported by the software developer. So it's quite common for people to still be able to download the program or potentially have it in all computers in your hospital or in the place that you worked at. But if you notice any glitches or anything like that, just be aware that the software developer no longer supports Aladdin. Interesting to note that in Australia, of centres that actually do use TDM, 20% of them actually still use Aladdin. So it's quite a historically well-known program. The other thing to be aware as well is Aladdin can't actually generate an empiric starting dose. It does require a clinician to actually select the first dose, whether you do that with a nomogram or a weight-based dosing that your centre is used to, before you can get the two concentrations that will allow Aladdin to generate the dosing recommendations. So this is just a really quick look at what the actual interface of Aladdin looks like. This is a courtesy from one of my colleagues in Melbourne. So essentially, you pop in your patient details on the side here. You include the dosing information of the dose that the patient is receiving and the actual concentrations that you achieve at the two different time points. And what Aladdin does is it calculates all of the pharmacokinetic parameters that are relevant for your patient. So in this case, you can see that the area under the curve is about 100. I believe in these patients, they used to target an AUC of about 80. And if you have a look down here, it's recommended a dose reduction to 220 milligrams, and that will give you an AUC of about 80 to 90. Now, the next program that's probably a little bit more advanced than linear regression-based programs is something called a population PK program. So it's very similar to Aladdin, but instead of relying on linear regression or mathematical techniques to determine your exposure profile, it actually uses a pharmacokinetic model. So if I draw your attention to the right-hand diagram here, think of this as your actual population PK software. You input your patient parameters and your dosing information and any TDM results that are relevant for your patient. What the program will then do is compare that to the pharmacokinetic model to determine what dose change needs to happen to be able to get you to your pharmacokinetic, your PK/PD target. It then generates an empiric dose which the clinician can then prescribe for the patient, and you can then repeat a separate TDM sample to see if you've achieved your concentration. If you are still subtherapeutic or toxic, you can obviously repeat this whole cycle again to get a new dose depending on your TDM results. Dose calc is probably one of the common ones that you might find described in the literature that uses this particular type of software. Similar to linear regression programs, unfortunately, there isn't a lot of prospective data out there about the accuracy of this approach. What we do know is that in this study by Mohan, they essentially compared two different methods for assessing AUC. The first one was utilizing dose calc to actually calculate the AUC based on one trough concentration. And the second group was done by clinicians who did it using two different concentrations, and they calculated it manually. And what they found was that the actual AUC that was calculated was very similar between both groups. So I suppose this potentially highlights the utility of these programs in centers where you may not have clinicians who are very familiar with calculating PK parameters, but you still want to use a PK/PD approach to your dosing. So this will actually simplify that process for you and potentially make it a suitable alternative. Again, very similarly to the linear regression programs, a lot of these are no longer supported by software developers, and that really limits the drug models to the default drug models that are actually already in the program. So if you now come across a new model that you think better fits your population of interest, it's going to be very difficult to actually get that model included into the dosing software. At the moment, the majority of PK programs only have aminoglycosides and vancomycin included in their programs, and that's because these are the agents that we traditionally used to do a lot of TDM on. They don't tend to have special populations in them as well. So for example, they don't tend to have drug models that are relevant for ICU patients or pediatric patients or patients who are on dialysis and so on and so forth. The next dosing program that I'll be talking about is something that utilizes Bayesian forecasting or Bayesian theory. This is certainly not a dosing program that is new, but it's really had a resurgence in the past 10 to 15 years or so. It's very similar to the PK model that we talked about in the previous slide, but when you're using a Bayesian program, there is an additional step that allows you to actually individualize the pharmacokinetic model to your specific patient. Now, you might ask, what does Bayesian actually mean? It's essentially a mathematical or statistical method of determining the probability of an event happening based on prior knowledge. Now, if we take that and think about it in a drug dosing perspective, the probability of an event happening is essentially the probability of you achieving your target concentration. And the prior knowledge is essentially your dosing information, your patient covariates, and your subsequent TDM data. So again, if we have a look at the graph on the right here, similar to your PK models, you have a PK model that underlines the backbone of this dosing program. You input your patient covariate data such as renal function, weight, height, and age. And if you know what pathogen you're dealing with, or if you have a specific MIC or breakpoint that you would like to target for, you can include this information as well. The dosing program will then analyze all of these different pieces of information here, and it will recommend a corresponding antimicrobial dose that you can prescribe for your patient. When you've given this dose to your patient, you can then collect a TDM result. And this TDM result is essentially used by the Bayesian dosing software to create an individualized PK model for your specific patient. If your subsequent concentrations are still subtherapeutic or toxic, it will then recommend an individualized dose that you can use in your patient. And you can repeat you can repeat the cycle as often as you need to. So with each subsequent TDM result, the model becomes more and more refined and potentially more and more accurate. Now, examples of dosing programs that utilize Bayesian software include things like Best Dose, DoseMe, IDODS, Precise PK, and InsightRx. I've placed InsightRx in italics just because there's something a bit special about it that we'll talk about in the next few slides. Now, the good thing about Bayesian dosing programs is that they tend to include a much wider variety of antibiotics that you can use in your program. So traditionally, the other models tended to be limited to vancomycin or aminoglycosides, but most Bayesian dosing programs will have beta-lactams, fluoroquinolones, antifungals, drug models included in their program. And it's certainly not just limited to antibiotics. There are other things that you can use it for, such as anticoagulants, chemotherapeutic agents, and other agents like that. So what is the evidence for using a Bayesian approach to optimize antimicrobial dosing? So there was a study that was done by Zhang earlier this year that was recently reported. And what they did was a randomized control trial comparing clinician-based dosing of vancomycin compared to dosing software, Bayesian dosing software guided dosing. Now, just to be aware, in this particular study, the standard of care in the hospital that they did the study in, clinicians would actually dose vancomycin according to a patient's renal function or clinical response, not TDM results. For the purposes of the study, they said that the target for vancomycin should be a trough concentration between 10 to 20 milligrams per liter. And what they found was when they actually used a Bayesian dosing software program to guide vancomycin dosing, a higher proportion of patients actually achieved this target of 10 to 20 compared to the clinicians. So in the clinician group, only 46% actually achieved target, and it was up to 69 to 70% in the Bayesian dosing software group. They also noticed that there was a much lower rate of toxic concentration. So 45% of the clinician-guided dosing had toxic concentrations, and only 26 with the Bayesian approach. Now, some of you might ask me, well, that's not a very scientific way of doing TDM. I mean, most people would probably dose vancomycin according to levels as opposed to renal function or clinical response. So we've got this second study here by Berthoud from 2019, and similar thing, they did a randomized controlled trial as well, clinicians versus Bayesian dosing software. The interesting thing about this study is that all the patients were actually dosed using a continuous infusion, just because this was standard therapy in this particular hospital. Most of the time, we would think as a continuous infusion as something that's very easy to dose for with VANC, and that's predominantly because VANC has fairly linear kinetics. If the AUC is subtherapeutic by 20%, you just increase the dose by 20%. So you'd think that it's actually quite a simple way of dosing vancomycin. In this study here, they targeted an AUC of 400 to 800. Despite being how simple we think it is to dose patients who are in a continuous infusion, they actually found that only 57% of patients who were dosed by a clinician achieved their target AUC concentration within 24 hours of their first TDM results. When they used a Bayesian approach, it increased to 85%. They also did a subsequent analysis just to look at trough concentrations, and they identified that they are, not trough concentrations, spot concentrations, because they're all in continuous infusions, and they decided that 20 to 40 would be their range, and still they found that only 38% of the clinician-guided patients received or achieved their target, and that was increased to about 68% in the patients who had Bayesian dosing guided software dosing. There are just a couple of more studies that I'll quickly run through. The first one by Hughes was a retrospective analysis. So they had an entire group of patients who were on vancomycin who were dosed by clinicians, and they looked at the proportion of patients who actually achieved their therapeutic target after their first TDM result. And that came back at 37.5%. Now, what they then did was actually took those patient parameters and input it into a Bayesian dosing software. And what they found was if they had used a Bayesian dosing software instead of the clinician-guided dosing, that number would have increased to 70.8%. So that's quite a marked difference, almost double. And at the same time, they also noticed that the amount of patients who had achieved an AAC above 400 was significantly increased as well. So a baseline of 72 with the clinicians and 93% with dosing software. The last study that I'll quickly touch on is an old one, but a good one. So this was a study that actually looked at the benefits of Bayesian dosing using aminoglycosides. So similar thing, randomized controlled trials of clinicians versus dosing software. Back in the days, they still used to target peak concentrations and trough concentrations as opposed to AUC, and their target peak was 5 to 10, and their target troughs were less than 2. What they noticed was that when they used Bayesian dosing software, the average peak concentrations actually increased from a baseline of 4.4 with the clinicians to 5.3. Now, interestingly as well, this was associated with a reduced length of stay in hospital, so 20 days versus 16 days, and there was a trend to lower incidence of nephrotoxicity as well. And this was probably being driven by a lower proportion of toxic troughs that the patients were getting. So 14.7 with the baseline clinicians and 8.7 with dosing software. Now, the last dosing software that I'll be talking about is something that uses artificial intelligence. Artificial intelligence is certainly not something that's new in healthcare. It's been used quite frequently for decision support programs, but its integration into dosing software is certainly something that's a relatively new occurrence, probably about in the last 5 years or so. Now, artificial intelligence programs utilize something called machine learning. And what machine learning is essentially a really large database that has a whole heap of retrospective data that the software uses to identify previous interventions that were associated with positive clinical outcomes. When you are faced with a new patient, what the program does is it recommends the interventions that were associated with positive outcomes, and it actually tracks the outcomes in your particular patient. If that outcome was positive, it will continue recommending that for that particular patient and future patients. And if it was negative, it would then try an alternative intervention. So it very much takes a trial and error approach in simple terms. Now, the way that AI actually integrates with dosing software is a little bit unclear at the moment. Just to be aware that any dosing software that is marketed to use artificial intelligence is actually a Bayesian dosing software that also has an AI component in it. So very similar to the previous slide that we saw, the dosing software recommends your initial starting dose, and then you get your corresponding antimicrobial concentration. And then the Bayesian side of the dosing software then individualizes the model to your patient. At the same time, what probably happens is that this individualized PK model is then compared to a large database that houses information from other patients, and it combines both models to formulate a refined model, which is then somehow integrated with the Bayesian model that you have. And then you get your recommended dose, and this cycle can repeat as previously. Now, the only dosing software that I'm aware of that is marketed as using artificial intelligence is something called InsightRx. So like I said, it uses both Bayesian and an AI approach. Again, because this is fairly new technology, there's not actually a lot of prospective data out there looking at the dosing recommendations from this technology. Of the studies that are available, there is a study that compared the accuracy of InsightRx to calculate an AUC. And this particular study just used one trough concentration to calculate the AUC. And what they found was that it was fairly similar to when clinicians actually calculated it manually. Now, the thing to note is that in this particular study as well, there were other dosing softwares that were involved. So there was Best Dose, DoseMe, and Precise PK, and all of these are Bayesian dosing programs. And the overall outcome was all of the different dosing software seem to predict AUC at similar accuracy. So the exact benefit, I suppose, of having this additional artificial intelligence component is not quite clear at the moment. But as more studies come out and as the use starts to increase in the literature, we might be able to delineate that a little bit better. This is just a summary slide that just shows you how therapeutic drug monitoring integrates with dosing software. So you have your more traditional methods of utilizing TDM results. You've got your dosing nomograms that can generate an empiric starting dose. Some dosing nomograms have the ability to interpret therapeutic drug monitoring results and can then give you a recommended dose based on your concentrations. If that's not available, clinicians can empirically start a patient on a particular dose of an antibiotic, and then based on the therapeutic drug monitoring results, you can then empirically adjust the dose of your antibiotics. Now, we've covered these 3 different dosing softwares, so I won't go into too much detail, but essentially you have your linear regression programs that utilize 2 concentrations, and any recommended dose changes is based off elimination data only. You have your population-based dosing programs whereby any dosing recommendations is based off the original population model, so that may or may not be appropriate depending on how well your patient fits in that model. And the third one is with the Bayesian or AI approach, whereby the recommended dosing changes are actually based off an individualized model that the dosing software has created for your patient. This is the last summary slide comparing all the different available approaches. So in terms of prescribing empiric starting doses of an antibiotic, the linear regression programs do not have the ability to do that. Population PK and Bayesian programs usually do because there's an underlying PK model that's the backbone of your dosing program. All of them have the ability to change the dose of your antibiotics in response to TDM results. The number of TDM samples that you require to be able to use the program is 2 with linear regression programs and 1 with population PK or Bayesian programs. Now, it's currently unclear if using more than 1 concentration increases the accuracy of your dosing recommendations. The literature seems to be a bit inconsistent with this. When there are differences, though, it tends to be a difference of about 10%. So that may or may not be clinically relevant depending on the setting that you're in. All of the programs have the ability to use non-steady state concentrations in making their dosing recommendations. In terms of altering PK/PD targets, so this might be useful if you have a very resistant pathogen with a higher MIC. Linear regression programs do not have the ability to alter the PK/PD targets. Some population PK models do, and all of the Bayesian, or majority of the Bayesian programs will have the ability to do that. Now, in terms of customizing the PK model, so you have a specific model that you want to use in the dosing program. That's not possible with linear regression programs because there is no PK model underlying the program. With most population PK models, dosing softwares, probably not because they're no longer supported by the dosing, by the software developers, sorry. And with the Bayesian approach, it's variable. Some programs market the ability to do so, whereas others don't. The ability to refine the underlying PK, it's not relevant for the linear regression programs. You're not able to do that with the population PK programs, but you are able to do that with the Bayesian programs. In terms of support by software developers, we've discussed that before. And integration with local electronic health records. So by that, we're meaning, is the program able to automatically extract patient parameters from your local electronic health records and directly input it into your dosing software? So it's no for linear regression, no for population PK, and variable for Bayesian or artificial intelligence programs. Some reportedly work with applications such as Cerner, whereas others advertise the ability to customize it according to the local program that you use. And that's it. Thank you.
Thanks, Gene. So just a general question from me is that, do you think you should just have a small number of pharmacists in a hospital who are experts in this? Or do you think this should be now generic knowledge for, say, pharmacy students now?
That's an interesting question. I think as time progresses, this will become more and more common knowledge. In the meantime, it's probably not realistic to expect everyone to have a good awareness of PK/PD endpoints, which is probably why it makes, if you have the resources to do it, to have like a select group of people who might be able to advise you in certain complex scenarios. And if that's something that you definitely don't have the resources for, then some of the simpler programs that automatically calculates an AUC is a fairly foolproof way of potentially targeting your dosing.
And so say non-infectious disease departments, say oncology, for example, are they using this sort of software as well?
Yes, so there's definitely a lot published out there with the Bayesian approach, whereby they've looked at PK/PD targets for chemotherapeutic agents, looking at the rates of toxicity between groups where they were dosed by clinicians versus dosed by the dosing software. And there's quite a bit of evidence out there for that.
Great, thanks, Gene. I'll just see if there's any questions online. I've got one here. With a Bayesian iterative approach, is a single drug level sufficient in the first 24 hours versus 2 drug levels?
Yes. So with the vancomycin studies that I talked about previously, they all utilized just one trough concentration, and that appeared to be relatively equal to when clinicians dosed it using 2 different concentrations and then manually calculated the AUC.
Great. Thanks, Jane. Excellent.